session that's going to feature 3 TED-style talks that will describe pivots during the COVID-19 pandemic. We're going to have 3 pre-recorded presentations followed by a live Q&A session with the presenters. I'm going to introduce all 3 right now before we start. The first one is from the VA, presented by Sarah Grimsgaard and Allison Whitehead, addressing accessible and on-demand integrated medicine and healthcare solutions from the Department of Veterans Affairs. The second talk by Françoise Adan from Cleveland is on supporting university hospitals employees during COVID-19 pandemic through integrative health services via something they call UH4U initiative. And the third talk from Michael Egan and Nancy Van Sloun from the Penny George Institute for Health and Healing and Allina Health in Minnesota, transitioning a group visit for chronic pain to a telehealth platform during the COVID-19 pandemic. If we could turn on the videos and we'll see those. I'll see you in about 30 minutes.
Welcome everyone to our presentation on accessible and on-demand integrated medicine and healthcare solutions from the Department of Veterans Affairs. My name is Sarah Grimsgaard. I'm a health system specialist with the Integrative Health and Whole Health Education Program. I'm joined today by Allison Whitehead, National Program Lead for Integrative Health. Just a quick disclaimer, there are no conflicts of interest to report for any authors associated with this presentation. 3 main objectives today in this presentation are to describe the whole health system model and the use of virtual care to expand access and accessibility to integrative medicine and whole health approaches. Also to share virtual self-care resources that have been created and made available on demand for both veterans and employees. And list our virtual training opportunities that are available for VA providers in an effort to expand access. VA has been a leader in telehealth for decades. We have offered many different connected care resources for veterans to engage in their healthcare. The VA has different mobile apps, different prescription refill, text message reminders, secure messaging where veterans can actually communicate with their provider and their healthcare team, and home telehealth options available. The slide represents the exponential growth in telehealth overall throughout FY16 to FY20, and you can see a tremendous amount of growth related to COVID-19. Whole health care is an approach to healthcare that empowers veterans to take charge of their life and health. There are 3 components to whole health care. Empower, which is the whole health pathway. It's a partnership between peers and veterans, where veterans get to explore their mission, aspiration, and purpose and begin their personal health plan. Well-being programs really focus on self-care and equip veterans with skill building approaches and potentially even health coaching. Whole health clinical care is the interaction between clinicians and veterans around whole health approach-based care. Within all 3 of these components, there are virtual care delivery options. For example, within the pathway, taking charge of my life and health is a veteran-led facilitated group where veterans can participate in a video visit if they can't make it to their medical center or if they're faced with access or geographic barriers. Within the well-being program, our VA medical centers offer tele-yoga and tele-tai chi, among other different approaches virtually, so veterans can experience these from the comfort of their own home. In addition, VA whole health clinicians can offer video visits for any of their patients that fall under virtual care. This slide really demonstrates the virtual whole health care growth over time. We've started tracking this type of telehealth work in fiscal year 17, and you can see just exponential growth over time, specifically between fiscal year 19 and fiscal year 20. That top line there in blue represents encounters, so a visit with a whole health provider, essentially, a telehealth visit with a whole health provider. And the second yellow line indicates unique veterans. So that's the number of unique veterans that are actually engaging in these virtual care encounters. You can see between fiscal year 19 and fiscal year 20, a 10-fold increase in encounters. Taking a deeper dive, we can see that our top telewhole health activity occurs among 5 different approaches: individual whole health coaching, whole health education, clinical care, yoga, and Tai Chi. And you can also see the difference between fiscal year 19 encounter count and fiscal year 20 encounter count. It's important to know that these 5 approaches don't make up all of the activity going on within these fiscal years. In fiscal year 19, we actually offered whole health approaches with 19 different approaches virtually. And fiscal year 20, we offered 30 different whole health approaches virtually total.
Now I'll talk a little bit about the progression of our national support and resource development from 2017 to the present. So we really began with an operations supplement in 2017, or sort of a guide for our facilities across the country to help them sort of understand what they might need to consider when starting up a telewhole health program. We then realized we needed a task force, so we recruited some different subject matter experts to join us in thinking through what might be needed or what kind of support we could provide to the field. Next, we developed a dashboard so that we could be able to pull and track some of the data that Sarah shared, and just to really see the growth and maybe where gaps in delivery of telewhole health were across the country. We also shared veteran-facing virtual experiential resources, so various experiential resources available to veterans on their tablets, on their phones, on their computers, so they could sort of get used to using or experiencing whole health and integrative health in a virtual setting. We also knew that we needed to support our virtual providers. So you all may be able to relate to this. We had providers who might be delivering yoga or Tai Chi classes or other types of integrative health services, but who had never delivered them via telehealth before. So we developed a training to be able to support our virtual providers. We've also developed how-to guides on virtual delivery and a virtual facilitation toolkit. And then in April, we launched our Live Whole Health Self-Care Series blog, as well as our Live Whole Health mobile app, which was launched in October. Then that brings us to the present day, where we're working on approach-specific resources. So for example, tips and tricks around delivering yoga or other movement types of services via telehealth. And then we're also looking towards a more targeted regional effort. So looking across the country, sort of in a hub and spoke model, looking at sites or facilities or regions that might have a little more going on with telewhole health, or more resources that they can use, and then connecting them with other facilities that might need a little bit more support. So I mentioned our Live Whole Health mobile app. This is the one time during the presentation that we're going to encourage you to take out your phone. So open your camera, check out that QR code, and download the app now. So this mobile app, which was launched again in October, was designed to develop a personal health strategy for improving overall health and well-being. It guides the user through a personal health inventory and creating relevant SMART goals. And there's more information at the website there, and hopefully you all downloaded it or are using it already. Also, I mentioned our hashtag Live Whole Health Self-Care series for veterans. So this launched in April, really out of a need for regular touch points with our veterans at a time when most services were shut down. So this is a weekly blog series, and it highlights different self-care resources and includes an audio or a video recording of a variety of experiential sessions such as self-massage or acupressure, yoga, and meditation. This is posted to the Vantage Point blog, which is available to anyone, so veterans, staff, caregivers, the public. It's also posted to VA social media, so Facebook, Twitter, Instagram, and housed on VA YouTube. I really encourage you to check it out. In addition to pivoting all of our virtual care, all of our care to virtual sessions, we've also been pivoting our education and training. We have some online on-demand trainings available, including Intro to Whole Health, Whole Health for mental health. We have live interactive experiential courses as well, including clinical whole health courses and whole health pathway courses. We also have these hybrid live and online skills-based trainings, including trainings for clinical hypnosis and coming soon, guided imagery and acupressure. And of course, we also support our facilities in field-based education, including for general whole health education and whole health clinical care. So thank you all so much for your attention, and we look forward to your questions. Thank you.
All right, we are here to talk about the response of university hospitals in Cleveland when facing the COVID-19 pandemic to support its employees. On March 17 last year, I received a call from our CEO who was concerned by the well-being of our employees facing and living the pandemic. We know that burnout and compassion fatigue are part of the risk of being a caregiver, but adding the pandemic, the isolation, the fear, the unknown, the unpredictability, the losses, we all knew we had to do something. So we organized ourselves in a small task force, representation from nursing, HR, employee assistance program, communication, behavioral health, and the Corner Integrative Health Network. Which was remarkable is how fast we operated with a sense of urgency. Processes that usually takes weeks, if not longer, were able to go through and achieve within hours. And within 3 or 4 days, we were in operation. What did we do? We created this platform called UH for You. And I'm going to guide you to all the things we did. But what's important is we didn't let perfection stop us and paralyze us. We started and then we evolved, constantly learning from our lessons and the feedback that we received. We started by creating a digital library with countless of resources, ranging from childcare to food insecurity to tips for parenting, and also a schedule and a living calendar for all the classes that we provided. We launched a call center. We trained about 30 employees to make sure that people were available at a call center around the clock to either respond to a call or an email. And the call center was there really to provide support, allowing people to vent, ask questions, access resources. And the mission, the tone was very particular. We said to people, treat people like they are family and don't let go until you find an answer to their questions. A fun and project was Adopt the Floor. So we know we live in a physical distancing time, but that didn't mean that we had to be socially distancing. So we had a lot of opportunity to continue to build on our community and had, for example, administrative building adopting clinical floor and sending notes, snacks, gifts, surprises, something that provides joy to both the giver and the receiver. My heart is just bursting with joy from expression of encouragement the team is sending. We created a team of critical incident management team provider that were able to be delegate and allocate as needed to offer support in aftermath of any incident and literally accelerate the training, the healing, and making sure that all employee assistance program had increased access in case the demand increased. We purchased an app through Health Journey and made this guided meditation app available to all our employees. It was frankly a surprise to us as we announced this and we shared this with our employee. In ours, we had more than 3,000 employees downloading this app. We also created almost unlimited, but a lot of different classes and workshops every day, weekend included for our employees. This had twofold purposes. When we launched a UH for You, the mission was to support the entire caregiver team. But for me, as a director of the Corner Integrative Health Network, I was concerned by my own team. That time we had 62 employees, and I wanted to make sure that everybody would maintain a job despite the fact that all outpatient services were suspended. So we had to reinvent ourselves, and a lot of our providers and instructors became teacher and providing classes to our community, ranging from acupressure to self-massage and stress management. And since the class were able to be accessible anywhere, you can see that the family and the loved one were able to access it as well. I'm so happy that these classes have been offered for engagement point. We created incentive, and I look forward to future schedules. I'm really enjoying them. University Hospital is a system-wide regional healthcare system. We cover the entire Northeast Ohio, have 22 hospitals across the region. We serve 1.2 million of patients and have a revenue of 4.4 billion. Every single hospital created a lavender room, a room where inpatient workers can take a breath, can take a break, comfy chair, nice lighting, guided meditation, aromatherapy, and healthy snack. Listening to our employees, we also knew that what would be very helpful is making sure that if they were sick with COVID-19 and quarantine at home, having food delivery would be appreciated. The most successful initiative we created is this one. Since April 2nd, we had sent daily email to our entire 30,000 employees. The format is simple, it's supportive, positive, it's short. We always share a tip, for example, how to practice gratitude, resources, how to access food insecurity, and also an uplifting moment. Maybe it's a quote, a song, or a selfie that people are taking, for example, when they were getting immunized. It is been really, frankly, a surprise to us that despite this being ongoing since April, beginning of April, this continued to be the highest rate opening of all the emails that our employees receive. Lots of appreciation. Just wanted to let you know that I look forward to receive the UH for You self-care emails. They have made a difference in my outlook for the day. The future of UH for You. It has had such an impact in our organization that it's certainly here to stay. It has evolved since we started and will continue to evolve. It has created a new line of communication. It had a tremendous impact on our culture, where we know that self-care is not negotiable and it's now supported encouraged model by our leaders. It had created an opportunity for fundraising, and we actually started to doing this. And of course, plenty of opportunity for my colleague in the research world to develop metrics and measure the impact. We also have learned that we need to do a better job in disseminate the information. Not everybody has access to emails or computer, especially from home. It has been a pleasure to be here with you. And if you have any questions, drop me an email. Thank you.
Hi, I'm Dr. Nancy Van Sloan, an integrative medicine physician at the Penny George Institute for Health and Healing, part of Allina Health in Minnesota.
And I'm Michael Egan, a traditional East Asian medicine provider at the Penny George Institute. And we are delighted to be with you today, at least in the virtual world, to share a bit about the pivot of our group visit for chronic pain from an in-person visit to the virtual platform.
We all know that chronic pain is a huge systemic problem in our culture, and conventional ways of addressing pain often are not effective and don't take into account the whole person. People who suffer with chronic pain can feel overwhelmed and very much alone.
And as the pandemic hit, patients had less access to care and fewer resources available, which increased the sense of isolation and emotional and psychological stress, which can all have an impact on chronic pain. All of these factors contributed to the evolution of our Transforming Pain shared medical visit. And today, we'll be presenting on our pivot from the in-person group visit to the virtual world. But first, a little backstory on the origins of the program.
The Penny George Institute for Health and Healing is an integrative medicine organization embedded within Allina Health, a large healthcare system in our area. The Institute is comprised of integrative medicine physicians and nurse practitioners, traditional East Asian medicine providers, psychologists, dietitians, and it provides classes in mindfulness, Tai Chi, and Qigong.
Nancy and I have worked together in the same clinic for several years. And over those years, in treating patients with chronic pain, we had really very interesting organic conversations. And what we found is that some of our patients with chronic pain needed more tools and more support than we were currently able to give them.
Also, through our conversations, we started learning from one another. I was learning about the traditional East Asian medicine view of chronic pain, and Michael was learning about the neuroscience of chronic pain. As we talked about creating a group visit, we wanted to incorporate these two paradigms as a way to explain and treat pain, while also capitalizing on the Penny George Institute strengths, which include programs such as Tai Chi, Qigong, and mindfulness.
Say that 10 times fast, Nancy.
Tai Chi, Tai Chi. The premise of the program is that chronic pain is a whole person condition involving mind, body, and spirit that involves changes to the brain. With the education and tools of the program, we're trying to change the brain in ways that will reduce pain over time.
Or from the traditional East Asian medicine viewpoint, trying to create a free flow of mind, body, and emotion in order to reduce pain.
The components of the program were chosen in part because there is evidence for pain reduction with them, and we wanted to empower our patients with a skills-based approach. We like to say the group is medicine, and being a group setting with other individuals who get what it's like to live with chronic pain can be very powerful and healing. In addition, education helps participants understand how mind-body tools can reduce pain and change the brain.
Mindfulness, Tai Chi, and Qigong have all been shown to be safe and effective modalities for addressing chronic pain. And they also allow us to work more skillfully with unpleasant thoughts, emotions, and sensations, and to develop a different relationship with the sensation of pain. Tai Chi and Qigong provide a gentle and safe way to move, which can empower patients to overcome the fear of moving due to pain.
Each week, patients had an individual visit with me, which allowed the visit to be billed to insurance. Then we met as a group of up to 8 patients. Michael and I facilitated each group together. The visit itself lasts 2 hours. It would start with 30 minutes of group check-in and sharing time. This was followed by 30 minutes of education on a different topic each week, and then 45 minutes of Tai Chi and Qigong practice and instruction together. And we ended with 15 minutes of wrap up and homework review.
Each week consisted of a different educational topic and its relationship to pain. And this slide shows the topics that we've kind of developed over the past several years. After 7 in-person cohorts, our observations were that those who attended the majority of the sessions embraced the content, did the practice, and completed the homework had significant improvements. And this was confirmed by Promise 43 data that we collected at the beginning and end of the program for each cohort. And we were all set to offer the 8th cohort in the spring of 2020, but the world had other plans. And as the months of restrictions from the pandemic persisted and people with chronic pain had less options for addressing pain, we started to explore the possibility of offering the program in a video platform.
In order to accomplish this, we need to determine what video platform we would use. Zoom was not an option at our organization due to privacy concerns, and we tried another one but found it just wasn't going to be suitable. We finally settled on Microsoft Teams, and that was just being rolled out at our institution at the time. This allowed us to have up to 10 people on the screen and to be HIPAA compliant. We normally handed out the content and materials each week at the in-person visit, but we instead needed to print up the materials ahead of time, and participants came to the clinic before the start of the program to pick up those materials along with the 2 books that we use in the program. We had to change some of the content to reflect changes in the course with it being offered in video versus in person.
And we needed to do some tech rehearsals and some dress rehearsals prior to starting the program. And thankfully, we have an excellent administrative team that really understood the technology of Microsoft Teams, because we don't. We had to take extra care around patient privacy and confidentiality, as we couldn't control the patient's environment. So participants needed to be in a private space with the appropriate technology and needed to have enough room to practice Qigong freely. We had to generate awareness around the billing requirements and documentation needed for a video visit. And we had to make sure that we could get enough people on board to launch a group virtual visit for chronic pain.
We had our first virtual group of 8 patients last fall, and overall it was a success. We were happy with how it all turned out, but it didn't occur without a few speed bumps along the way. We needed to have our tech support on site available with us the first 3 weeks to help us troubleshoot technology issues that came up. For each visit, patients were given a Microsoft Teams link to meet individually with me prior to the start of the group meeting. These were brief 5-minute visits, so when there were issues with connecting or with audio or video not working, it was a big issue and made it difficult to stay on schedule and to start the group visit on time.
After the individual visit with Nancy, participants logged on to the group visit using a second Microsoft Teams link. We'd then do the group check-in, the educational topic, and mindful movement or meditation practice, and give the weekly homework assignments. And this was all pretty much similar to the group visit. We were able to set up our clinic studio with a webcam and a large screen, which allowed me to see all of the participants unless they were hiding from the camera, which is exactly what Nancy and I would prefer to be doing right this very moment.
We noticed some positive surprises from offering the program on the virtual platform. There was better attendance and lower attrition than with the in-person groups. In person, it was not unusual that a person would miss a group or 2, but that did not happen with the video offering. There were no longer barriers such as geographic location or weather, so we were able to draw from a larger area, and patients didn't have to worry about traffic or weather conditions in getting to a clinic. The outcomes were similar to what we observed with the in-person cohorts, and a surprise to me was that patients felt free to share openly on the video platform, and they were able to connect and support one another in a way that was similar to what we had observed with the in-person visits.
Overall, the Tai Chi and Qigong practice went well, but there certainly were some limitations. Practicing together in a group has a synergy that the virtual world just can't recreate. At times, giving individual adjustments or instructions was more difficult due to not being able to see all the participants, but overall, the effectiveness and ability to deliver the content virtually was similar to in person. And we're happy to say we're all set to offer another virtual offering later this spring.
To sum it all up, a video group visit for chronic pain is an effective alternative to an in-person offering. It can improve attendance and access to care and decrease the sense of social isolation that these patients often experience.
Well, that wraps up our presentation today. We want to thank you all for sharing it with us. We hope that you stick around after this for some questions. Thank you so very much for allowing us to participate in the conference. We wish you a wonderful rest of your day and a wonderful conference. Thank you very much.
Let me invite our panelists to come back online. And I've been following the chat. This is quite a challenge to actually try to capture many of the questions that come through. So I'm going to apologize right now to anyone who listed a question that I didn't get to, but I've got a few that I'd like to begin, and I'm going to go in order initially, which is I have a couple for our VA group, I have a couple for Francoise, and a few for our third presentation. So let's jump to Allison and to Sarah. There were a number of questions about challenges, either engagement challenges or cultural challenges between the VA, the veterans, and what you were trying to share with them, some of the practices. Can you speak to that at all?
Sure, I'll start, and then Sarah, if you want to jump in. And I think luckily we've been, working on whole health and implementation of integrative health for a while now in VA. And so transitioning over to telehealth certainly has some challenges. I do think that there are some, differences in delivering this care virtually, and I think there's some need for a building of, of trust between patient and provider when doing something, totally different and new. I think a lot of us maybe had been used to doing video meetings in the past, but it's possible that, some of our veterans and some of our population, this might be very new to them. But Sarah, anything that you'd like to comment on that?
Yeah, sure. I think some distinct challenges that, we've noticed with the transition is essentially when working in a group, the technology in the beginning wouldn't allow for everyone within that group to be seen at a given time. Luckily, the VA went through an upgrade to the technology, and now more video screens can be seen in a single session. So that brought a lot of clarity and hopefulness to not only the providers, but the patients that were engaged in that particular session. I think, the accessibility and the technology has been around for quite some time. We've been offering telehealth for decades in the VA, so it's nothing really new for our veterans. I think the transition, like Allison said, is a little bit different and scary in the beginning, but on site, there's so many different supportive staff in the world of telehealth that can walk veterans through not only the technology and the equipment, but the session itself.
That's great. I want to transition to a question that I'm actually going to ask everybody to address, which is we're hearing about pivoting during the pandemic to the virtual environment. And of course, part one of this is, can we make it work? And I think you're each showing that you can make things work. The question is it effective? And so the question for the VA group, for both of you, Allison and Sarah, is you've increased tenfold the number of visits and the numbers of people engaged. Is there any data on outcomes? Are the vets healthier?
Yeah, great question. And something that we are getting ready to launch now actually is a big, robust sort of look at telewhole health and the impact that that's having. And so as soon as we have that, I'm sure our research partners who are doing that will be on one of these next meetings presenting that data, but certainly something that we're really interested in. And I think there's some smaller, facility specific looks into that. But Sarah, anything to add related to the outcomes?
Nothing yet, but I think that research effort will be really exciting.
Well, that's great, and congratulations. I may come back to you. Let me pivot to Francoise. There was a lot of kudos in the chat about being very able to quickly connect with 30,000 employees and folks that are affiliated with your health system. I think one of the questions that comes up regularly here is, how was that funded? How many FTEs did that take? There's a lot of components to this. You had 30 people, you said, in a call-in center, you have content, you have classes. Put that in context with how much of that was emergency and how much of that is going to go forward with basically new line items for the system.
Great. Good question. Thank you, Adi. So in terms of extra cost, it didn't require anything. We kind of reinvent and repurpose ourselves, so to speak, especially for the call center. Imagine that we were in lockdown, a lot of the services being shut down, and people really need to find another way to work. So we kept people working in a different ways. And that really lasted for months. At this point, the call center is just managed by 1 or 2 person because it's not as acute as it was. In terms of same thing for our classes, people needed to have, we literally pivot, right? Repurpose, so to speak, our employees. And then when we talk about our email, well, no extra cost either. It takes a few hours on a Sunday and a great team to put it together. And certainly a passion of people who are excited about contributing. I think that, for us, the catalyst was the sense of urgency from the CEO who said, okay, you have to do something and do it fast. And then with that urgency, really break a lot of barriers.
I appreciate the part about repurposing people and giving them work, but what's missing is the revenue stream. It's one thing if you're working with patients, it's another thing if you're working with employees. So maybe one more word about that. Is there a direct support by the system, or was this just an expectation for you to pick that up?
No, so certainly for a while, our revenue went down, like probably most of you. But surprising it to us, last year ultimately was one of our biggest year, because I think that, it was kind of free marketing, so to speak, not really free. It's never, nothing is ever free. But imagine that, we became really in the eyes of 30,000 plus employees every single day. And so that has actually catapulted us to another stratosphere, literally, in terms of demands. And so our revenue first went down, but then went back up with robustly. So last year was our biggest year ever.
Well, I would imagine daily emails certainly gives you awareness and recognition by the teams. That's wonderful. So thank you. And let me turn to our group from Minnesota. To Nancy and Michael, questions about your billing model. How did that change? You can notice there's a theme here about revenue and about expenses, but if you could just share a little bit about how that evolved.
So you said billing model, correct?
Yes.
So it's billed as a shared medical visit. I am the only one initially when we started the program who could bill, and the billing is based on, for people who bill, it's a level 3 typically is what the requirements I can meet. And the one-on-one touch point with each patient is required to bill it as a shared medical visit. So that's very brief. It's 5 minutes or so of time, and then additional history that I would gather within the group and whatever billing requirement that allowed me to meet, but typically it was level 3. So in the first several groups of the year, Michael's time was needed to be supported by my billing because he was not able to bill. The billing really didn't change with it being on video. The reimbursement was the same, at least in our area, for in-person versus a video visit. We did finally start to pilot billing for Michael's Tai Chi and Qigong instruction. And so that's just something that came about at the same time as the first video offering, so that he also then is bringing in some reimbursement for the Tai Chi and Qigong portion of it.
Yeah,
and
we had
typically been able to at least break even with that. Go ahead, Michael.
Sort of to back up to that question and what was talked about during the opening discussion about the viability. We originally got a grant from the George Foundation to start the program, but what we were able to show was if we were running at 8 people with Nancy billing, we were able to show that it was financially sustainable. And so then, we looked at, I had advocated for a long time, and then we got a lot of support from our admin team to bill Qigong as group exercise, because under that non-discrimination clause in the Affordable Care Act, if it's in my scope of practice to teach Tai Chi and Qigong, payers should be reimbursing for that. So some payers are paying and others aren't, but I think it's really a big deal to move in that direction.
So this is a question to you, but I actually would like the others to answer as well, which is, it's one thing to pivot in a state of emergency to a new platform to continue to offer services. But then there are aspects about the virtual environment and the experience that actually is better than it was in person in terms of accessibility, the lack of travel, the things that you said patients enjoyed. To what extent are you going to continue virtual visits in what you're doing, or even expand them, or are you actually going to scrap it and go back to in-person? Let's start with the Minnesota group, then Francoise, and then BA.
We haven't had to answer that yet because it's still virtual. We just started a group last week and the conditions require it to still be virtual. My guess is that it would probably be some of both, because we can just draw from such a larger geography with it being virtual. And it really did increase the ability of people to attend every single visit. So that was very noticeable. The attendance was different. But I think there is also that component of practicing Tai Chi and Qigong together, which is just totally different. That is valuable also. I was very surprised by how much the group came together and supported one another. I didn't expect that. Whether it was exactly the same as in person, I can't say. Michael, I don't know if you have anything to add to that.
I would just echo all of that, Nancy. I mean, I think that if the technology supports it, doing things virtually potentially allows more participants to be engaged at the same time, so you don't have the spatial constraints. And with Minnesota weather being what it is, we did have some attrition on evenings when people couldn't make it into the clinic. But there is, for me, there is a humanness to the in-person experience that just was not the same. So I hope that we can continue the program in person.
So we've got about 2 minutes, so let's take about 30 seconds each to answer that. Francoise, what's going to continue?
Both. I think we are certainly going to continue a hybrid model, hoping that insurers and payers will continue to allow for telehealth billing. In terms of employees, we have a lot of success and offer a lot of flexibility to do it virtually.
And Allison or Sarah, one of you.
Yeah, I was just going to say, I think a hybrid model is definitely the way that we will see VA going. We saw encounters increasing even before COVID, and even now when some sites are opening, some services, we continue to see growth. I think Sarah maybe touched on this or can provide a lot more information in the future, but we're also looking at a sort of clinical resource hub model in VA. So having these sort of hubs in different regions that can help provide the virtual care. So perhaps, and this is just my thought, perhaps some of the on-site care is still happening at a local facility, and then some of that virtual care could happen through these resource hubs.
Well, thank you so much. And thank you for being so succinct and to the point. There's still questions in the chat. I encourage you to go back and see those, and maybe you can answer individuals directly. Thank you all for attending. We're going to bring the session now to a close, and we'll see you in the other sessions. Bye, everyone.